So good morning, everybody. And we now move to the slide muscle, the obliques. And yes, as mentioned, the obliques are some the muscles which many beginners are a little reluctant to touch. So let me start with a simple question. Is over elevation in adduction, is it same as inferior oblique overaction? Right? Inferior oblique overaction presents with over elevation in adduction. Is it the same? The answer is no. Many of these over elevation in adductions could be due to something else, like this is a nuance with an upshoot. So any inferior oblique overaction is not the same as over elevation in adduction. So the indications of inferior oblique surgeries would be a V pattern with inferior oblique overaction, a primary inferior oblique overaction which is often associated with infantile esotropias, intermittent exotropias, acquired esotropias, or DVDs with inferior oblique, or superior oblique paresis with an inferior oblique overaction, or a large excyclotropia. These are the conditions which need inferior oblique weakening surgeries. A slight bit about the anatomy. The inferior oblique is the only muscle which arises out of the annulus ossin from the maxilla, and it goes on inferiorly in close association with the inferior rectus and the lateral rectus. At the insertion, it lies at very close proximity to the macula, and it is in close association with the vortex. So you should be very careful when you are isolating and hooking the inferior oblique so as not to injure the vortex. Now, an important bit of anatomy is the neurofibrovascular bundle, through which the innervations run, and which also carries the parasympathetic fibers to the pupil. And when you change the path of the muscle, like in an anterior transposition, this neurofibrovascular bundle actually becomes the new origin. There are many inferior oblique weakening procedures. I will list them out one by one, and I will tell you which one I prefer. Before we start isolating the inferior oblique is isolated in the inferior temporal quadrant about 8 millimeters from the limbus, and once you incise the conjunctiva, the muscle lies right in front of you. But it is more easily said than done. You can also hook the lateral rectus, and you can pass a suture for better exposure, especially for beginners, and then you can expose with muscle hooks that area, and the inferior oblique lies right in front of your muscle hook, so carefully hook the inferior oblique. A word of caution over here for beginners: you can actually cut the conjunctiva a little more than what you see over here, so that you don't have any extensions, ragged extensions into the conjunctiva later on. Now let me describe recession first. Recession is weakening along the course of the muscle fiber. So here we commonly do what is called as the classic 10 millimeters Parkes recession, where we recess and put the muscle 3 millimeters inferior and 2 millimeters lateral to the lateral border of the inferior rectus muscle. And the Fink's point, which is 8 millimeters recession, is 4 millimeter inferior and 4.4 millimeters lateral to the inferior rectus border, lateral border of the inferior rectus. You can see that we have hooked, and now we have cut the muscle with the artery forceps. We will now tag the muscle. We will now suture the muscle with interlocking bites. You can see in the lower video more clearly, we will put interlocking bites on the muscles, and then we will attach the muscle 3 millimeters inferior and 2 millimeters posterior to the inferior rectus lateral border. Now we actually disinsert the muscle, cut the muscle, and then we attach the suture because it's easier to do that. And now you can see in the lower video, we are attaching it slightly inferior and lateral to the inferior border. And when we do it at a bunch. We don't splay the fibers. Now coming to anteriorization. like you saw in recession, where we were keeping the fibers in the direction, in anteriorization, we keep the fibers anteriorly. We change that, alter the path of the action, and we keep it adjacent to the inferior rectus border. And the same video, the same way you will isolate the inferior rectus, keep interlocking bite suture, and then attach it to the sclera right adjacent to the, see the hook is the inferior rectus, and you place the suture right adjacent to the inferior rectus muscle. In the modified Elliott-Nankin technique, you place it slightly posterior to the inferior rectus insertion. Now, there is a concern about what is called the anti-elevation syndrome. So what is the anti-elevation syndrome? Anti-elevation syndrome is limitation of elevation of abduction in the operated eye. So you keep the muscle exactly next to the inferior rectus, and this causes the limitation of elevation and abduction. And there is a consequent overaction of the contralateral inferior oblique. It is said that the risk of anti-elevation syndrome is less if the fibers are bunched up instead of splaying in the insertion. Now, a relatively newer procedure, anterior nasal transposition, where instead of transposing on the temporal border, you transpose the muscle to the nasal border. So inferior oblique is transformed from an extorter into an intorter. The indications would be a severe excyclotorsion, sometimes seen with dystostosis, and with DVD with over-elevation in adduction. Another very common procedure which used to be done is the myotomy. Myotomy is nothing but isolation of the muscle, putting two clamps, and then cutting the muscle between the two clamps. So you can see the two clamps being put, and then we will simply cut the muscle between the two clamps and cauterize the ends. The only problem with this is that the muscle tends to get attached exactly at the point where you have left it, or somewhere where it wants to attach and starts overacting all over again. So it doesn't serve the purpose for a very long time. An alteration to this procedure is myectomy, where you cut a slab of muscle, about 5 to 8 millimeters of the muscle piece is removed, and this can correct almost up to 5 to 20 prism diopters. In the place where I trained, Shankar Netralaya, Dr. Surendran just does myectomy with extremely good results. So myectomy is a very simple procedure. You hook the inferior oblique and place two artery forceps at a distance of about 5 millimeters, and then cut off the segment of muscle between the two artery forceps. This is a little self-adjusting procedure, but again, the disadvantage is that there is a high rate of inferior oblique overaction post this procedure after some time. And if you want to do a resurgery, you really don't know where your muscle has reattached. And you can't tailor this procedure. This is the all or none procedure, even though it's called as self-adjusting. But the advantage is that you can do it faster, there is no scleral pass, so chances of complications are less, and many surgeons prefer myectomy. They will not do recession. Now, nasal myectomy has been described for additional procedure. If you have done one procedure and your inferior obliques are still overacting, you can go for a nasal myectomy where you cut off a piece of the muscle instead of from the temporal side, from the nasal side, a slab of muscle is cut off. It is a further weakening. It is a secondary procedure. Extirpation and inferior oblique fixation to the orbital wall are also secondary procedures done when inferior oblique is overacting in spite of the first surgery. Complications could be over and undercorrection, which is overcorrection is common. Recurrent overcorrection is quite common with these procedures. Fat adherence, pupillary dilatation, hemorrhage are all complications which has been described. And which procedure I prefer? I have now switched over from myectomy to recession because number one, we can find the muscle if we want to use the muscle later on for any other procedure. Number two, it can be graded. As you could see that we can do 10 millimeters recession, 8 millimeters recession, and you can do a differential recession if there is asymmetric inferior oblique overaction in the two eyes. Coming to now misbehaving superior obliques, which is a little more difficult to tackle. Now, indications for superior oblique recessions would be A pattern and Brown syndrome. I'll quickly wrap it up. And the weakening procedures could all be tenotomy or a posterior tenectomy, which is commonly done. Isolation is in the superior temporal quadrant, usually in 8 millimeters away from the limbus, and the superior oblique is hooked under direct visualization. You can hook the superior rectus, and then you can see the muscle. If you put your DMA rays, you can see a fan-shaped muscle just adjacent to the superior rectus insertion. Or you could just directly find the muscle once you actually expose it. You can just pass the hook and expose it to find the fan-shaped insertion. Remember, it's a fan-shaped insertion, so be careful to include all the muscle in your hook. Now, posterior tenectomy is when you selectively spare the anterior fibers and cut away the posterior fibers. You can see that we are separating the fibers, and we will cut off the posterior fibers and keep the anterior fibers. Anterior fibers are the tauters, so you will not have any torsion following the posterior tenectomy. It works well. This is a post-operative patient of A pattern, where the A pattern has completely collapsed following a posterior tenectomy. Now, expanders are to increase the tight muscles, where you see we can expand it either with a 250 band or a suture, so that the tightness of a muscle, which is often seen with Browns, could be reduced. Usually can lead to fibrosis and extrusion of the band if it is not sutured well. And you can use chicken sutures also for Browns. This is a chicken suture being put, a non-absorbable suture placed at a lax in the muscle in the nasal half, and then you can just cut between the two muscle, usually lengthens the muscle by about 5 to 8 millimeters. And you put the suture and then simply cut the muscle to increase the length of the muscle. The complications could be superior oblique palsy, a worsening of the DVD fat adherence. So to summarize, careful selection of patients and selection of the appropriate procedure with meticulous dissection and use of magnification like a microscope will go a long way in producing good surgical results. Thank you.